Welcome, everyone. It's lovely to see you all on this sunny October afternoon. I always think this is the best time of the year in England. Don't know how you feel about that, but I arrived this time of the year many years ago, and I've always had a soft spot for this kind of weather. We are going to keep it very short and sweet to start with, and then hand over to Dr. Tim Ferris, who we're obviously really pleased to have here today, and that's obviously why you're all here. Tim will do a presentation, and then there will be time for you to ask questions. In the meantime, you can obviously download your thoughts in the chat. We often run events that are very lively in the chat, and we might not be able to get around to everyone in terms of responding, but certainly we learn from that, and you can engage with each other and so on. If you are calling in, you can also, and you're not on Zoom, you can email us thoughts and questions, or if you have any problems, you can email info@National Voices. I'll hand over to Aaliyah, who will talk you through the technology now, very briefly. I mean, most of you will be used to it by now, but just by way of reminder, over to you, Aaliyah.
Fantastic. Thank you, Charlotte. Hello, everyone again. So we are very much seasoned Zoom professionals, I feel, at this stage, but just in case you needed a little bit more guidance around the tech for today. So as you can see along your bottom panel, you should be able to see on the bottom left your microphone and your camera, so you'll be able to flick those on and off where necessary. Please, as we've mentioned, feel free to engage via the chat as well. We have some wonderful colleagues who will be monitoring the chat and being able to pick up some of your comments. We've turned on auto captions here just for anyone who would require that to engage with the session completely. And then you may also go to reactions alongside the bottom panel again and select raise hand if you'd like to contribute, and we'll do our very best to get to you in this session as well. Thank you.
Thank you, Aaliyah. Do we have a sign language interpreter on the call who we need to highlight, or not today? If you do, just tell Aaliyah, tell Jess, they'll make sure that you can be visible. Before I hand over to Tim, who's obviously the main ticket for today, I just set the scene very, very briefly as to why we thought it was a great idea to invite him along, and why so many of you obviously decided to join us. So Tim joined the executive team at NHS England as Director for Transformation not long ago. Before then, he was a non-executive director, and before then, he worked as a doctor and an academic in Harvard, Massachusetts hospital as well. So he comes with credentials, and he's been widely traded as a good thing for the NHS. So we can kick the tires on that assumption today. The transformation agenda feels sometimes a little bit overblown to us, I think, in the patient sector. We probably talk more about improvement and maybe change, but it'd be interesting to have that sort of unpicked a bit, maybe with Tim's help today. We are clearly a network full of innovators, if you want to call it that. Many of you are in the business of inventing different ways of addressing old problems or new problems. I'm just reminded, and a colleague of mine pastes that into the chat right now, of some work we did halfway through the pandemic with organizations that work in peer support. And many of you are obviously in the peer support space, who had to adapt really quickly to the new conditions as they prevailed, because peer support is very much fundamentally based on people being together in the same space, and that was not possible during the pandemic. So we brought all these organizations together who had innovated and gathered the learning and synthesized it and shared it widely, and it's been described as a really useful resource. And I just thought it might be quite useful for you to see that many of us are constantly innovating by necessity. A lot of this innovation is in the non-medical, non-technical space. But what I think would be interesting for us to explore together is how can we bring these different innovation cultures together. For me, there's two main points at which we need to bring the power of the patient sector and the community sector into the innovation agenda. One is to identify the priority areas for change. Where are the pressures the highest? Where is the need not being met? Where is who are the communities who are not well served by existing formal services. We are very well placed to help the system figure that out. So that's what you might call need identification or prioritization for innovation. And the other one is sort of maybe at the other end, and it's about patient pull. How can we get to a place where communities and people can drive through innovation that they think is useful? And how can we accelerate the uptake of good ideas so it doesn't take 10 years for a good idea to percolate through the system, or even longer? And I think both of these areas, unfortunately, are a bit underpowered right now, and it'd be interesting to see how Tim and his team will respond to that challenge. I think I'll leave it there because we have time for more discussion later. And I'll just hand over to Tim, who will talk to us until about 2:30, and then we open it up to the floor. Tim, I believe you didn't bring slides, so we could just bring your face into the conversation. But introduce yourself as well, if you. Thank you.
Great. Can you hear me? Great. Okay. Charlotte and the whole National Voices team, thank you very much for this invitation. It is really an honor and a real pleasure. I want to start off by saying that you can tell by my voice, and you know from what Charlotte said, I'm not from here. And though I speak English, I speak the American brand of English. And I've noticed, I've been here just over 3 months now, that sometimes what I reference in a word, especially in talking about conceptual things in medicine, the translation isn't as good as it could be. And so I wanted to start off by saying, I have not, what can I say it this way? The communications team hasn't let me out very much in the past 3 months. And so this is very much a test of my message. And so I am really excited to be using and have the opportunity, the platform that Charlotte and her team have provided at National Voices to test the message. Because I'm still learning and I'm still testing. So with that big caveat, let me say a few things about how I have approached the challenges that the NHS is facing, and I use the word our because I'm part of this team that you're all part of, our aspirations for the future. So I'll start, and apologies if I'm going to cover some territory that you know, I'll do it very briefly, but it's always been important for me my whole career to think about what the big picture is and the context. And so I start with the 4 aims of the delivery of healthcare. And the 4 aims of the delivery of healthcare are great care that produces more health, great service, caring service to the people who need care, value to the people who are paying for care, and sustainable, even, dare I say it, motivating work. Like the workforce, it's not, we can't provide those other 3 things on the backs of the workforce. The workforce has to be engaged and enjoy their work. And I'll give you one little specific piece of information that I learned a long time ago. If you do surveys of patients and look at what the prediction of their satisfaction is, economists like to throw in tons and tons of variables. If you throw in all the variables into a model, the model that comes up as the most predictive of a patient satisfied with their experience of care, the single most important variable is that the people they received care from were themselves joyous about their opportunity to deliver care. Right? So in that quadruple aim that I just described of service and that other one of sustainability, actually those 2 things are directly related, right? So the quadruple aim, the 4 aims, everything we do has to be in service of one, at least one, if not more of those aims. But then let's take it down to the NHS right now. So, and Charlotte mentioned she's back in the office. I'm going to take that as the launching pad for, we are in a new phase of this pandemic. And we are moving from pandemic to endemic. Pandemic means that it is the virus, in this case, is causing a problem. Endemic means it's in the background. Coronavirus is essentially a cold virus, and there are already a number of cold viruses circulating throughout the both hemispheres, and it looks as though we are likely to have that same situation with the COVID virus, that it will be an endemic virus, but it won't cause the devastation that it caused because we will all have some immunity to it. We will have some immunity to it because we either got COVID or we got vaccinated. So we're in the mid phase of that transition, probably, hopefully, from pandemic to endemic. It looks like it's going to be a somewhat slow transition, but nonetheless, we are already very focused in the NHS about delivering those services, returning the services, and even more of what we needed to do before. Because as you know, we have a capacity crisis in the NHS. And that's not anything, that's no secret. And the capacity crisis has multiple origins. But without getting into the origins, the fact is that the care the population needs and the infrastructure and people available to deliver it are not well matched. That is a big problem for the NHS, and the NHS needs to face that problem head on. It is also an opportunity because it is actually through the work of the pandemic and the ability of the NHS to respond rapidly to changes in the environment that there is greater confidence in the service that we actually can transform. We can make big changes relatively quickly. And that is actually what will be called for in this capacity crunch that we're facing. So there are 2 priorities. One is pandemic recovery in all its forms, and we can spend time on that in the question and answer, but there are a lot of different manifestations of that recovery. But I wanted to highlight the other big priority that Amanda Pritchard, the new CEO, has been focused on whenever she talks about the NHS and its future, is health inequalities, and how the pandemic really highlighted really unacceptable health inequalities and inequalities in the delivery of services. This is really a challenging area, but as I have traveled around England the past several months, it is incredibly motivating to everyone who I have met in the NHS to be part of the team that is addressing health inequalities. This is something that is visceral, that they can feel in their bones, it is really important that we take on that challenge and address that challenge. So 4 aims, 2 priorities, then there's getting even more specific, long-term plan. So the long-term plan, predated the pandemic. All of those challenges that were in the long-term plan are still there. And I'm not even going to go into the list. There are over 200 deliverables in that list. Actually, it's really an inventory of all of the areas where the NHS needs to up its game. And so that's okay. So now it's challenging. So we've got the quadruple aim, the two priorities, the two priority areas that need to be spread across all the long-term plan goals. And then you've got me and the transformation directorate. So what I came is I have the honor of leading 3 groups within the NHS National. And those groups are NHSX, which is the sort of strategy around digital and digital transformation. NHS, the Improvement Directorate. So that is, how does the national team support the local team's efforts to improve their own delivery of services? And the third is the Innovation Group. And the Innovation Group is really, although I think we will orient it a bit more toward internal innovation, it's really about how do we go through the process of getting external innovation developed by tech companies, by biotech, by pharma, by software companies, there's a huge industry of people in lots of different technology and people-based activities outside of the NHS, whose services the NHS could and should use after carefully evaluating, right? And so what is the process for getting the benefits that they offer to the citizens of England in a more, let's just say, in a more, maybe actually, to use Charlotte's words, she said, it takes too long. I think I wrote it down. Actually, it takes too long to get innovation into and then spread throughout. And we need to do a better job of that. So those are the 3 groups within the NHS national team that I am been given the honor of leading. And so, having said all that, let me say that, you know, it's typical of a new person who comes into a new leadership role. So the first thing you do is you ask a lot of questions. And I'm a naturally curious person and have learned an enormous amount. I love being on the steep end of a learning curve, and I expect I'll be there for quite some time. But at some point, a new leader has to say, okay, there's a few things that I need to really push hard on, because they are gonna, if I focus on those things, they will disproportionately lead to the benefits that we all aspire to, disproportionately lead to improvements in our performance in the long-term plan, disproportionately lead to making good on those 2 priorities, pandemic recovery and health inequalities, and disproportionate impact on those 4 aims that all healthcare delivery systems have. And so what are those 3 those 3 levers? This is where I'm hoping that my American English translates all right. So the first is end-to-end pathway redesign that is tech-enabled. Okay, so let me explain. Let me unpack that. So one of the reasons that I was so excited to come here from the United States, because the United States, as you may or may not know, delivers healthcare in different commercial entities across an individual patient's healthcare path. As a physician who practiced my whole life in the US, 30 years at Mass General Hospital, and who took many family members, including my 2 parents, through multiple journeys through our healthcare system, the lack of joined up care across those different commercial entities creates enormous friction for both the patient and also for the people providing care. That friction is a source of enormous frustration for anyone who uses the healthcare system. Now, what's interesting to me is when I describe my experience of healthcare in the US, I describe it here and people say, oh, you know, we've got friction too. Even though we have a national healthcare system, actually we have friction in the patients, from the patient's point of view or the citizen's point of view. It is not necessarily easy to navigate across the patient's journey. We can do better. And that was one of the things that I was so excited about coming here, because at least in theory, the NHS owns the end-to-end, both ends of that pathway, right? And everything in between. And so at least in theory, we should be able to deliver, I won't say frictionless, but I will say less friction in that process, taking out waste, taking out frustration, enhancing communication, all of those things. So, and making it tech enabled. And this is where, you know, we don't need to deliver healthcare the way our grandparents got healthcare, which is sort of on a one-to-one transaction basis. That is very necessary for certain types of interaction, but there's a ton of healthcare that could be delivered really differently if we just thought differently about how it's being delivered. And you know, all of you use your smartphones to do things which, when you were kids, that you couldn't imagine doing those things. Like, why can't we do more of that? And actually, as a great illustration, the NHS app, which pre-COVID was used by a couple million people, is now used by 17 million people. That's extraordinary. And honestly, in my system in Boston, I could do everything that I needed to do for a patient. I could do on my phone, prescribe, refer, everything, talk to them, video conference, everything. And everything a patient needed to do, they could do on their phone, right? And so that needs to be an option. It's not the only way. And we will always have face-to-face. I don't want to make any you know, statements. The channel that patients use to get their healthcare, they should be able to pick that channel. And previously we just had one channel, which was face-to-face visits. Now we have more options, right? So end-to-end redesign of the delivery of care to lower the friction. That's number one. Number two, second pillar, data and analytics. So a lot of healthcare is about supply chain. Now, patients don't see a lot of that, but imagine the orchestration that needs to occur in an operating theater with all of the people and devices and equipment that needs to come together in one room, in one moment in time, to be delivered to make patient care excellent. It is actually an extraordinarily difficult supply chain problem. You multiply that times all the theaters in this country, and you think about the logistics behind that. And right now, that all of those logistics, the supply chain logistics in healthcare, are managed by what I would call local organizations. And it's very clear that supply chain logistics are much more efficient if you do them at greater scale. And so making sure that we have, if, for example, Emily Lawson, who was responsible for the vaccine program, had near perfect visibility of every dose of vaccine from the moment it entered this country to the moment it went into someone's arm. That kind of data is incredibly valuable for delivering services. And we want to make that data available to the people who are managing healthcare locally and build the infrastructure necessary to make that data available in order to give them the tools to run more efficiently. So that's data and analytics. The third.
How many pillars have you got, Tim?
3.
That's good.
I'm just about done. So the third pillar is actually, Charlotte, I'll call it the Charlotte pillar, which is speeding up the rate with which innovation is made available to the citizens of England. And that's about coordinating the recovery trial, which was able to enroll 40,000 people in just a few weeks in order to demonstrate that dexamethasone was life-saving in ICU patients with COVID. So that's the kind of rapid scale that it takes scale to bring that kind of innovation and to answer the question, is it or is it not effective, quickly, so that then we can move on to new things. We need to be more organized about it. We have a path for doing that, and it's a very exciting prospect. Let me close my remarks, Charlotte, by saying just a couple more quick things. First of all, we need to manage long and short. And long and short means we have some immediate priorities and we have some long-term aspirations. We need to make sure that we are addressing our immediate priorities using the tools and by building the infrastructure that gets us in the direction of our long-term aspirations. And actually, that comes down to very specific decisions. And then I want to close by talking about the relationship between national and local, because national does not deliver healthcare, right? National's goal is to help the people who are delivering healthcare enable them to do a better job, support them in that role. That means a lot of communication up and down, and it means that there really should only be a few national programs, because you always hear that local is like there's too much stuff coming from above, and that doesn't give them the bandwidth to just think about what they need to do locally. So we need to find communication that makes sure we're balancing that communication and those initiatives. And let me just close by saying that there is so much great innovation inside of the NHS. Every time I go someplace, I see extraordinary innovation. I think, wow, it would be great to spread that innovation to more, because then I go to a different place, a different practice, and I see a different innovation, and I think we need a lot more cross talk about the great innovation that's going on to spread it internally within the NHS, because there's terrific appetite for it, there's terrific innovation, and extraordinarily caring people dedicated to delivering patient services. So, Charlotte, I've gone 2 minutes over. Apologies.
Tim, that's entirely allowed. I just, we obviously don't want people to go 40 minutes over. Thank you, Tim. Very clearly structured, and I can tell that you are rehearsing a pitch and have obviously rehearsed this before. I'm yet to hear surfacing that where people and communities fit in, but I wonder what my colleagues make of that who are on this call. I think to start with, I'm going to ask Michelle from Alzheimer's. Michelle, what did you hear? What do you make of it?
Hi, thank you for that. Thanks so much, Tim, for talking then. It was really interesting listening to that as someone who works in the third sector. So I'm in the innovation team at Alzheimer's Society, and our work focuses on creating solutions to improve care and support for people affected by dementia. We're currently working on a guide for designers, engineers and entrepreneurs on how to co-create with people affected by dementia. And this means going beyond consultation and having people with personal experience of dementia shape the project, often from the very beginning. And we'd be happy to share that guide once it's finalised. Our research for the guide has highlighted the importance of this approach, both in empowering marginalised voices and producing solutions which match what people actually want, need, and will work for them in practice. Without this co-creation, you risk spending time and money developing something only to find it doesn't work in the real world. So what I'd like to ask you is, how does co-creation feed into what you do? And how do we break down the barriers to testing and implementing our co-created innovations, tech and non-tech, within the NHS? And then I've got a third point, but forgive me if that's too much to go through. And how can charities and the NHS work together to meaningfully involve groups beyond their individual networks?
Thank you, Michelle. So there is a question on co-production and really understanding user need very deeply, but also not just describing people as a bottomless pit of needs, but also helping them come up with solutions, supporting solution creation and where that fits in the innovation cycle. And then also question around partnerships and where the NHS and the VCSE could partner better. Before I bring in Tim, I thought I'll bring in Jennifer from Roche. I bet you also have something to say about partnerships.
Yes.
Over to you.
Thanks so much, Charlotte. Tim, thank you very much for the opportunity to ask you a question and for a really helpful presentation. As Charlotte has certainly mentioned, my question also kind of focuses on partnership. I was really struck by your point around the concept of the places where you see focus for disproportionate effect on the broader system, and one of those being pathway redesign. Given the folks on this call represent, health and social care organizations to pharmaceutical companies, where do you see, like, any of us on this call practically being involved in those redesign processes? And if you have time, I would appreciate a bit of a reflection also on kind of where you see this power, this collective power on kind of reaching people beyond that one-to-one, face-to-face service provision setup that you mentioned, and really speaks actually to Michelle, the work that you seem to be pursuing. So thank you.
Yeah, great question there. Obviously, partnership is one of those, hardy perennials of the work I engage in. I like the idea of thinking through this kind of reach we have, as a community and as a network. How could we bring that to the Transformation and Innovation Challenge? We convene people in a way that no one else, I think, in the system does. Anyway, Tim, what do you make of Michelle's and Jen's points?
Well, I think they're not just great points, but they are essential. So I've been through many journeys of innovation and transformation, and I can't think of an exception to this rule, although maybe there are some. But when that journey starts with co-creation, it actually always, in my experience, maybe I'm wrong, takes more effort up front, but it always ends up in greater effectiveness and greater adoption further down the road. And so it's simply not, maybe I failed to mention it because it's it seems so fundamental that you would want to start every pathway redesign. I mean, if we're talking about citizen-centered care, doesn't the citizen need to be in the room when you start that discussion? I mean, yes, absolutely. And I will say that the pathways initiatives that I have seen have all had patients in the room. And so there's some pathway development work around eye care. There's some pathway development work around musculoskeletal, and there's some pathway work around cardiac. Now, there are many pathway work going on all the time throughout the NHS, but the specific national programs that have been in place, they predated me by 6 or 9 months. They all have patients involved in the process, coming into that process through charities, through patient organizations. Well, honestly, I know the landscape very well in the US and where I would go. I don't know the landscape well here. Part of my being part of this conversation is actually to meet people. But fortunately, the people who I'm working with on my team, they do know where to go and are involving the patients, and they need to. So co-creation, absolutely. I also want to point out that it's a complex environment because it's co-creation across a bunch of different stakeholders. Healthcare, as you know, so there are, I could lump them all together and say, oh, well, they're the professionals. Well, actually, those professionals don't necessarily like to be lumped together, because what the doctors want, what the nurses want, what the allied health professionals want in a particular pathway actually can be unique and need to be paid attention to. So, and those are just the professionals. They're the operations managers, they're the tech people, and very, very importantly, at the center are the patients, and the patients themselves have multiple voices. And so orchestrating that process is a really big challenge. I'll just put it out there. It's a really big challenge. But what I've seen in the past, people say, it's such a big challenge that I'm not going to try. And that, to me, is not an acceptable answer. Like, you got to try, and you won't get it right. It will never be perfect, but you have to make the effort, because you will end up with a better product, a better innovation, and you will learn along the way about how to do it better the next time. So absolutely co-creation, patients, providers. And so I'm really glad, Jen, that you referred to the pathway redesign, because that's the area where it is absolutely relevant. I do want to highlight just very quickly, though, that it's also very relevant in the work on the innovation side when we're bringing commercial stuff in and testing whether or not it's like now that's not co-creation so much as it is co-evaluation, and so it's a somewhat different role, but critically important. I hope I've addressed those.
Excellent, thank you. I'll collect another couple of contributions. So Will, I saw you were up, and also Sue Brown from ARMA. Will, you're from the Health Foundation. Just briefly also say maybe hi.
Hi, Tim. Hi, everyone. Will Wilberton from the Health Foundation, Director of Improvement. And thanks, Tim. Excellent introduction. I really wanted to pick up on this question around accelerating the rate of learning and innovation between organisations. The research we've done suggests that actually, organisations still find it hard to make time, and clinical teams and still find it hard to make time to look out. How can the national group help with the spread of innovation, with making it easier for people to know what's working elsewhere and get practical support in how to take up these ideas? Because yeah, we're strongly of the view that if we could get everyone up to the standards of the best, then we'd be in a very, very good place.
Excellent. So the role of the centre in accelerating uptake and accelerating improvement and supporting improvement. We keep that, park that. Sue Brown from ARMA. Do you want to say who ARMA are? Because people might not know.
Yeah, so I'm Sue Brown from ARMA, which is the Arthritis and Musculoskeletal Alliance. So the first thing I want to say is absolutely brilliant to hear musculoskeletal given as an example. It's fantastic the way MSK is finally being taken really properly seriously by NHS England, which is brilliant. And I've been involved in some of these pathway redesigns that are going on in that space. But my question was really about where does prevention fit with all of this? Because the pathway design seems to always start at the point where someone's actually already got a problem. And it does sometimes feel like the NHS is constantly trying to deal with the leak by getting a bigger bucket. And it says, when we've got a big enough bucket, then we'll tackle the leak. And it feels to me like we're never going to have a big enough bucket unless we tackle the leak, because the leak is getting worse. And I think that question applies both to the issue of trying to get some more alignment between the needs and the resources to meet those needs, but it's also absolutely critical in the equalities question, because that's where your prevention stuff could have the biggest impact.
Yeah, and before I hand over to Tim, I wonder whether I could bring in Kem, who's asked a question around, you know, the needs of people who also, as well as living with ill health and disability, live with disadvantage or discrimination. Kem, do you want to come in there? Because I think that would segue quite nicely.
Hi Tim, I'm Kem Worthing and I'm an associate lived experience advisor. My background is I am a carer and I'm an associate with National Voices. As you was talking, I was reflecting on you saying that patients are in the room. So my question really was, it's great that they are in the room, but how do you bring in their creativity and their insight and the difficulties that they have to help shape those priorities that you mentioned earlier?
Especially obviously where they have difficulties that are exacerbated by inequality. So we have, you know, a set of thorny questions that would very easily take us to 3 o'clock without anything else. The role of the centre in making this work better, and we know that innovation has to happen in places. Prevention, I mean, that is a challenge and a half. And then the whole inequalities agenda, and how can we get innovation focused at the wrong end of the inverse care law, which is where I see not that much of it happening.
Yeah. So I think I'll have to make sure that this does go to the end, because the questions are getting harder as we go on. And so I'm really scared about what comes next. So I'm going to be, Will, I apologize. I'm going to be a little wonky in my response to your question, and say that I think accelerating the rate of learning and spread has 3 elements to it. One is, it may surprise many of you, but it turns out that a lot of people who deliver healthcare have never actually seen data on how they deliver it compared to people right next to them, or down the road, or maybe in a different part of the country, or maybe in a different country. Delivering data that's, you know, one of my pillars, but the specifics of delivering data to clinicians, not as judgment, but just as this is what you're doing, and others are doing something different. I can just say that just in the last couple of months, we've been delivering data through the GIRF program to orthopedic surgeons about their rates of day cases for hips and knees, which I'll just say in the US, it's largely an outpatient procedure and not so much here. But the rates have really changed here because actually information was being fed back to the surgeons saying, hey, you know, your colleagues are doing this differently than you are. You should think about that. So that's one way of accelerating, is to just show people information. The other is when we're testing new things, I'm a really big fan of group randomization. So there's the beauty of group randomization is you can take an entire site and say, in this site, we're going to do it this way. And in this other site, we're going to do it a different way. That takes less infrastructure. You can still prove great things and do all the epidemiology, but it is much simpler to and costs less than other methods of evaluation. So where group randomization works, it can accelerate the testing of change. And then the last thing on that is you have to have accelerating spread is about conversations. and honest conversations about what the best methods are. And I'll just say, I personally am not afraid of having honest conversations. I, in fact, maybe I enjoy them too much. Now the prevention thing, can I just say a word about prevention? Something that I did not understand at all before I came here. So prevention is considered in the United States a part of medical delivery. Interesting, I got here, and actually prevention is technically in the delivering it maybe in the NHS, but the oversight and organization and the rules around it are actually a different arm's length body. And that's a challenge. It's an opportunity and a challenge, but I haven't fully got my arms around that. And I need to work with the other arm's length bodies that have a stake in prevention in order to come up with a plan on improving prevention. I will say that the current technology base on which prevention sits in this country is pretty old and pretty old-fashioned. Like, it's letters. And I'm not saying we're going to do away with letters. Letters, yes, we can still do letters. But I get reminders from my GP in the United States on a text about, I'm due for my fit test, or I'm due for whatever it is. And so I get to control the mode by which we have communication. We need prevention to the mechanics of prevention to sort of enter the modern world. And then the last thing about prevention is the science of prevention is really exciting. So you probably know and have heard about the Grail Gallieri trials. There are some really interesting, novel ways to approach cancer screening. It seems likely that a decade from now, cancer screening will be a blood test. And we are already in the process of evaluating the relevance of circulating DNA from a tumor that you just pick up potentially even much earlier than any of our physical screening tests. It'll be simpler, quicker, more effective. So that's an aspiration. The science isn't proven yet, but there is a huge movement to move in that direction. And the NHS should be one of the places that is testing those innovations so that we get it to the population of England as soon as, or sooner than other places. And then, so the question of how do we bring the patients into the room? So I really look forward to learning more about the answer to that question. I'm not going to pretend, well, you get to judge if my answers are in any way decent at all, but I'm not going to pretend to have the answer to that question. But I will say that I am really interested in learning from you what the answer to that question is.
Okay. Someone in the chat asked a question about the role of the ICSs. I wonder whether, I mean, they must have washed up on your desks by now. That is obviously an attempt to try to bring together treatment, care, prevention. What do you see their role in this, and to work in better partnership to leverage places into a different kind of working?
Yeah, so here, I guess what I would say, we have some challenges in front of us, and like all things, like all changes, big changes, opportunities and challenges. The opportunity here is that we have the potential to deliver services more effectively to people, because if all services across a geographic area, to be known as an ICS, are coordinated and visible from a management point of view, then if there's an endocrinologist with open slots at a different hospital. In the past, the GP at one hospital is unlikely to refer to that other hospital unless they have a relationship or whatever it is. But at least conceptually, in an ICS, you can do something called level loading, which is you can make sure that opportunities to deliver care across a geographic area are at least presented to the patient. The patient may not want to do that, but at least it's an option. So that's an important element of the ICS. The other thing is, I said before about friction. So let's use the formation of an ICS and the fact that I expect that in not too distant future, everyone within an ICS, all the providers, including care, not just healthcare, but social care, are working off of the same set of information about a citizen, a patient, and that would be a really good thing. Much less repeating your story, much less figuring out what actually your information goes with you across your ICS, and that means much more efficient, less friction. And the third benefit of an ICS, or the third thing, I think we have to be careful, because there's a risk with the ICS, and that is yet one more administrative layer, right? And I would be disingenuous if I didn't call that out, because it is adding an administrative layer to the hierarchy in the NHS. And we just have to make sure that as we put this in place, we don't let the construction of the ICS distract us from improving care, right? Because the goal is to improve care. And it is really easy to get distracted by organizational changes like this, but we just need to be focused on using the ICS to enable better care, and not, constructing an ICS for the sake of the ICS. So maybe I'll leave it there.
I've got one more very brief intervention from Kim. Kim, do you want to briefly say who you are and where you're from?
Thank you, Charlotte. My name's Kim Wire, and I'm from DEFCOG, which is an abbreviation for Deaf Cultural Outreach Group. So we're a deaf-led community organisation in the southeast of England. And we represent deaf people within the broad region of Sussex. So it's a larger region than just, so it's East Sussex, West Sussex and Brighton and Hove. We've been doing some good work in the area, and we've been really, had our thinking caps on as to how we can really support our community regionally, but also how that can impact on a national level as well. And we have been thinking about some concrete solutions, but because we're a small organisation, we're regional, we're talking to people at a level that is inappropriate for the suggestions that we have. It links in with pathway redesign. It links into what you've just said around the fact that patients, with long-term health issues, with disability or special needs or requirements, have to keep repeating their story. And it links into various things, but primarily it's around making sure that that information, the key information needed. So for our, from our point of view, it's around interpreters, and it may also be around ensuring that there's a PA available to support that person to go to an appointment, and that they're involved in making that appointment and being able to be present at that appointment, is maintained across all of the services, no matter what mode. At the moment, deaf people are getting letters or telephone calls, which is inappropriate. And the work that we do is phenomenal around addressing that and making complaints. And the time wasted and the a lack of efficiency in that is immense. And of course, primarily, the impact on the well-being and mental health of the individual is huge. So proposed solution that we have is to better safeguard critical details around specifically access and support. At a local level, they said there's nothing they can do, but NHS England letterhead is a centralised letter. So everything that's at the top. So I would propose around the NHS number that we all have on all correspondence, that there should be some kind of box that would have specific needs in terms of the accessible information standard available on every letterhead for every patient. And that information can be produced or shared by the patient around their particular needs. So it's putting that patient in the forefront of that decision-making process. And that information is available on every correspondence there is, so that interpreters don't get missed, that appointments then have to be delayed 2, 3, 4 times before they get to see a doctor with an interpreter. But also around the patient's, patient summary records, but also the GP has their own as well. So when you're talking about ICS, about linking up GPs, hospitals and everything else, that information gets passed on and there's no dropout, which often happens. So the question I have for you, apart from making the proposal, Tim, is how likely is that to be something that can happen in reality?
Thank you, Kim. It's just one of the examples of all the great innovations our members come up with and that are really bubbling up from a deep understanding of community need. So I'll leave you to answer that challenge directly, but I just thought whether, in wrapping up, and I won't wrap up myself, in wrapping up from your perspective, if you fast forward 3 years and you think, I've done my bit for the NHS, it's been bloody hard, I want to do something else now. What do you want to have achieved? What's the one thing you want us to remember your tenancy for? Are you gonna, you have had a lot of, you have obviously quite a sophisticated system of improvements you want to see going through, but if it was just one thing you could do, what would it be? I think that would help us understand where to plug in. Thanks, Tim.
Charlotte, thanks. And let me address the question first about, so in the medical record that I had, that took years to put in place and everything, every person who cared for every individual, part of that medical record in a banner across the top that was part of every view included patients' preferences, any accommodations that they needed. So all of their preferences for how they're contacted and their needs for whether or not they were deaf or the accommodations that they required. And the list is long, but that was always front and center in every single view. That should be an essential element of the shared care record. I believe, at least in theory, it is. It has not been as widely distributed, but if it is part of that, then making it printed on every letterhead is a simple thing. But you need to have a system that links that information to the patient, no matter where the patient is. We're not quite there yet in the NHS, but it is known that is a necessary and essential element of the shared care record. And I know that because the NHSX people are, and so I needed to say that because it is part of the journey. Now, if there was one thing I would say, it is that people feel that the NHS, is accessible, caring, and constantly searching for the solution to their problem. Mm-hmm. Okay. And that would be, Charlotte, I guess I would say that's a high bar, right? But if you need to shoot for something and have aspirations, the bigger sin is to shoot too low.
Thank you so much. Thank you so much, Timothy. And yes, I think we all, we're a small organization in a very large network, as you will have noticed, and we all aim very high. And I think you're right. It does give a sense of orientation and a strong sense of prioritization. It's been really good to have you here. You will have noticed how engaged people were with what you said, and how many thoughts are triggered there. And sure, we will continue the conversation and introduce people to you as and when you need that. Please do reach out. You know where we are. And I wish you a good rest of your day. Thank you for joining us, and thank you everyone for coming here today, all our partners and members and everybody who contributed and lent in. Thanks for your energy, and stay engaged. Bye-bye.
Charlotte, thank you so much.
Bye.
And thanks to everyone.